talk about the renin angiotensin system in the anti-hypertensive drugs. The four classes, good way to remember, is A, B, C, D. A is for ACE inhibitors, ARBs, and alpha-1 blockers and alpha-2 blockers. B is for beta blockers, C is for calcium channel blockers, and D is for thiazide diuretics. But before I go through how these work, we need to understand the renin, the RAAS complex system. So say a patient has a bleed and becomes hypotensive and starts losing blood volume. Juxtaglomerular apparatus or complex senses the reduced total body volume, reduced TPR through these baroreceptor specialized smooth cells called Poisson cells. They're separated by some connective tissue, and these cells are your macula densa cells, and they are chemoreceptors because they detect sodium. So sodium gets brought out into the interstitium 65% here, 25 here, and 10 here. So once you go hypovolemic, your body starts pulling sodium out more and more. So by the time you get here, you'll have less than 10%. And these cells are going to recognize that. And that's why they're called chemoreceptors. So what is this? This causes release of renin. And the renin goes through the efferent arteriole, renal venous return back to the IVC. The liver always producing angiotensinogen, but in this case, in the presence of increased renin, it starts making more. Renin is the enzyme that turns angiotensinogen to angiotensin 1. Angiotensin 1 is converted to angiotensin 2 by ACE, angiotensin converting enzyme. There shouldn't be an I there, that's just for the drug. That enzyme is located on the peripheral capillary venules. And so what is angiotensin? Oh, ACE also it breaks down bradykinin, which is a vasodilator, so you get further vasoconstriction. And angiotensin 2 is a vasoconstrictor, so it goes down here, and what happens is these green things here, so these are your capillary venules, and these are angiotensin 2 receptors, and when in increased levels, they vasoconstrict both in the arterioles and the venules. So what happens? Let's start. Okay, so the venules are vasoconstricted. That means that you get more cardiac, you get more venous return. 70% of your blood is in the venous circulation, but you get it more into the right heart. Believe it or not, that's a right heart. But so you get increased and diastolic volume because you have increased venous return. You get increased cardiac output, increased stroke volume, and due to increased preload and increased total peripheral resistance. All everything is doing is trying to uh, vasoconstrict to keep the blood pressure at suitable levels. Now that's renin. Um, the other way that renin is stimulated by secretion is this is the carotid sinus coming off the aortic trunk, and it innervates it through the glossopharyngeal nerve, CN12, through the medulla to increase sympathetic activity. And it does this two ways. One, it runs to the Poisson cells to stimulate even more renin secretion. And another way it does this is increase norepinephrine secretion to the target tissue, so the nerve endings attached to the target tissue. This could be the heart or a vessel, and you get decreased norepinephrine reuptake and increased NE, so you get vasoconstriction. And an important point that to know is in the presence of continuous angiotensin II activity, you get cardiac remodeling and congestive heart failure. And this makes sense because we know the pericardium is made of fibroblasts, and why do you get the boot-shaped heart, or not the boot-shaped heart, but why does the heart enlarge in congestive heart failure if the pericardium is made of fibroblasts, which are inelastic? And that's because angiotensin II promotes proto-oncogene growth, and you get more fibroblasts, and you get a phenomenon that's called cardiac remodeling. Angiotensin II also stimulates the principal cells on the distal nephron. And there's the nephron, by the way. And when you're hypotensive, by the way, your GFR infiltration goes down, and that's why these cells, sodium transporters, pull more sodium into the interstitium. So you get these P cells here at the distal nephron, and not completely wrong, but I have to make a correction. Angiotensin II stimulates aldosterone secretion at the renal cortex, zona glomerulosa cells, and the aldosterone stimulates the principal cells to produce, it enters the cell and it activates the gene to produce three different types of proteins. The first protein is these cells on the luminal lateral surface, the Na plus K plus ATPases. So what they do is they pull Na plus into the interstitium. So they're very high in K plus. And very low in Na plus on the inside, and it also makes a protein. It makes a sodium transporter and a potassium transporter. So it's high in K plus, so it has to excrete K plus into the urine. And Now remember how I said here it's going to be less than 10%. Well, the body is saying, hey, there's no sodium's real low. We're hypovolemic. So what it does is all the sodium that it has, it goes through the sodium transporter so it can be further transported into the interstitium, which is reabsorbed in the lymphatic system, which drains back into venous circulation. And what follows sodium, water, so you get total body water retention. Now, the ACE inhibitors, captopril, lisinopril, big high yield question there is they can cause dry cough and angioedema, and that's when you switch them to an ARB, angiotensin receptor blocker, so the angiotensin 2 can't attach to the receptor, and that's going to be your losartan. Then you have your alpha-1 blockers, which basically decrease sympathetic activity to reduce the blood pressure. Prazosin, tirazosin, cloxazicin, and alpha-1 blockers have a first dose syncope phenomena. Alpha-2 blockers use an opioid withdrawal, clonidine, methyl-dopa specific for pregnancy. Beta blockers are used in post-MI to prevent second MI. And angina. And that makes sense because very important to know there's beta-1 adrenergic receptors on the poikisin cells, so they block those and prevent the release of renin. Calcium channel blockers are your there's cardiac specific ones, non-dihydropyridines, diltiazem, and verapamil. And the way those work is they block the calcium from exiting the cytosol of and then consequently the sarcoplasmic reticulum doesn't have as much calcium to cause cardiac contraction. So you get a less forceful contraction, which is a big difference. Skeletal muscle, the calcium doesn't go through the cytosol to attach to the sarcoplasmic reticulum to cause contraction. So the other calcium channel blockers that work on the smooth skeletal muscle present on vessels are amlodipine, nifedipine. And then finally, diuretics, thiazide diuretics, hydrochlorothiazide acts right here on the distal convoluted tubule, sodium chloride symporter to inhibit sodium reabsorption. So the sodium's not reabsorbed, the sodium goes out with the water, you reduce your total body volume, and in turn reducing hypertension. I hope you found this video useful. Leave any questions, comments in the section below, and thank you for watching.